You're watching Training in Poorly Resourced Environments, produced by GP Supervision Australia and presented by Pat Giddings. We would like to begin by acknowledging the traditional custodians of the land on which this recording was produced and pay our respects to their elders past, present, future and their families.
It is a great pleasure to welcome you to this session that's been put on by the RVTS team, and they're talking about their work and their experience in working in training in poorly resourced environments, but very much with the focus of broadening that, I think, to your own experience, your own training setting, and how you can really not just manage a registrar there, but aim to excel. I might at this point hand you over to Pat, who can introduce himself and his team, and we'll make a start.
Thanks, Simon. Just to introduce myself, for those of you who don't know me, my name's Pat Giddings and I'm the CEO of our training organisation, RVTS Limited, and we're based here in beautiful but rather chilly Albury, as that's where our office is at the moment. But a lot of our team are distributed all over the country, and some are in much warmer places. I'd also like to acknowledge the traditional owners. Albury is in Wiradjuri country, and I'd like to acknowledge the Wiradjuri people as the traditional custodians of the land in which we work, and pay our respects to their elders past, present and emerging. I'd also like to introduce our panel, Belinda O'Sullivan. Belinda's an academic, a researcher who's based in Bendigo and has recently undertaken an evaluation of RVTS. Rhonda Gurney is our Director of Training, and Sarah Ferguson is our Supervisor Medical Educator, and David Baker, our Deputy Director of Training. And we've got two of our SLOs joining us as well, Peter Smith from WA and Valentina Bojic, who's in Queensland currently. So just looking at the objectives, the title really says it all: training doctors in poorly resourced environments. So that's really what we're drawing on here. We want to understand how to effectively support and train registrars in poorly resourced environments, and looking at some of the resources, technologies that we use as RVTS. We're going to have a couple of case studies, one about a doctor in a remote setting and another in an AMS setting. And we're also going to have a look at, we've now got some evidence to support what RVTS does, and we want to have a look at the evidence base, particularly from Belinda from our recent evaluation. So this is really drawing on the experience of RVTS. So just an overview of what we're going to do. We want to recount the experience of RVTS in supporting registrars in resource poor environments. Now, RVTS is a program that's based on remote supervision. By definition, virtually all the participants in our program are in resource poor environments. So this is a great opportunity for us to be able to review how we do that, look at the evidence, as I mentioned, some case studies, and then we'll see what there is of the knowledge that we've gained that might be applied in other settings. And we'd like to have some discussion around that. We certainly haven't got all the answers, but we've got quite a bit of experience in this area, but certainly not all the answers. So just a little bit of background about RVTS. The program was established back in 2000. So we're in our 24th year now, and we've delivered general practice training to more than 500 doctors in more than 350 communities across the country. And it's primarily aimed at rural and remote and First Nations communities. And our main tool is distance ed and remote supervision. That's our main educational delivery, is at a distance. And like other general practice training programs in the country, we're accredited by both colleges, and endpoints of training are the Fellowship of ACRM or RACGP. And training takes 3 or 4 years. We have 3 years of core training and the opportunity for advanced skills training as well. Currently, we've got more than 100 doctors in the program, and we've got another 21 starting in July, which is our mid-year intake. This is important because RVTS, unlike other training programs in the country, is really a workforce retention program. to be eligible for RVTS, you have to be already working in a remote location, in most circumstances at least anyway. And that would be previously through MD RAP, now the pre-fellowship program, or sometimes other general practice training programs. So therefore, we use education and training as our MO, as that's how we keep people retained in their location. And we'll explain that more shortly. Just to recap, as I mentioned, 80% of our participants achieve GP fellowship, which we think is pretty good outcome given the circumstances that people are working in. And almost 50% will still be in their training location 2 years after training. We have excellent workforce retention numbers. On average, registrars stay in their location for training 3.6 years, and they're in their location more than a year and a half prior to coming on. So that's 5.6 years that they're in the location, and then another half will stay on for another 2 years. So we get excellent workforce retention. The breakdown between the two colleges, 80% tracking towards FRACGP, 20% towards ACRM, and 80% of our participants are overseas trained doctors, 20% Australian trained. And this, I think, is a reflection of the workforce in rural and remote Australia, very much IMG dependent at this point in time. And I can't see that changing anytime soon. A considerable amount of those are dual pathway, and we do offer dual pathway. In fact, I think we're the only program now where you can do dual pathway. You can't sign up for an FRSGP if you're enrolled with ACRM and vice versa. We also run our AMS stream. So over the years, we've had 71 doctors now that have been entirely trained in Aboriginal community controlled health services. So this just gives you an idea of the scatter, and you can see that RVTS has had a presence in every state and territory in the country, but predominantly up and down the East Coast states. And that's just a function of population, of course. So what do we do? How do we do it? Well, we have 3 core years of training, and we deliver the knowledge-based elements of the curriculum via webinar, small group learning webinars, 30 per year for 3 years. And we have residential workshops up to 30 days over 3 years. And these are affairs that we bring all of our registrars along to, including supervisors and families as well. So they're a really big deal, but they're really great events. And we do 2 of those per year. Clinical teaching visits, we have at least 5 per year. And since COVID, we've found that we're doing a number of tele-clinical teaching visits, but we're sort of going back to face-to-face visits more now as well. But that's at least 5. If people need more, we'll do more. We have an online learning platform with lots of content, and we also have a peer support forum, which we use via WhatsApp. I mean, everyone seems to use WhatsApp now, but it works really well for our group. We get great interaction, and I got to say, I learn a lot from our WhatsApp group. And I think this is the key. This is the key element of RVTS, is the support that we have. Every registrar has a case manager, if you like. We call them registrar training coordinators. They have a supervisor, a dedicated remote supervisor. They have access to a standby supervisor in hours for urgent but not emergency problems. Each registrar has a medical educator mentor to guide them through the training process, a cultural mentor, peer support, very strong peer support, registrar liaison officers, and we work hard at connecting registrars with their local supports, and particularly the multidisciplinary team that's available to them. We also look at supporting families, and I mentioned before that we bring families along, we fund families to come along to our residential workshops. So why it works? Collegiality, the peer support and a sense of group belonging, regular face-to-face contact with doctors in similar situations. It develops a strong sense of belonging. High quality training support. We really do provide a very good product and very high quality training with registrars supported with lots of support from an individual case manager. Family support to attend workshops, flexible personalised approach, but also an acknowledgement that it's not for everyone. It's interesting to note that the average experience of a first year RVTS registrar is at least PGY 10. And I think at recent numbers, it might be more than that. And the average age is 40. So we're looking at a more experienced group here, which makes them more resilient, I believe. And here's just some comments that we get from our annual registrar satisfaction survey. And I won't go through them all in detail, but I've highlighted some themes coming out there. It's words like RVTS family, support, community, being part of a group, flexibility, and being taken care of. So just to summarise, we've been going for 24 years. We've had more than 500 doctors, in more than 350 remote and First Nations communities, really good fellowship and workforce retention figures, and I'd have to say off the scale approval from participants in the program. So it sounds too good to be true, I know, but I'll leave it at that. And Simon, I think it's time to hear from someone else.
Thanks. Yep. So we'll hand over to Belinda. And I just want to reiterate extraordinary contribution to the workforce to remote Australia, but so wonderful to hear of all those doctors trained in AMSs. That's just, you know, I'm a bit blown away by that as well. So thanks, Belinda.
Thanks very much. And hi, everyone. I'm Belinda O'Sullivan, and I'm joining to talk about the evaluation that's been done of the RVTS. Started in September last year and finished in around March this year. And I was on the independent evaluation team from the University of Queensland and working closely with Matthew McGrail, who some of you will know. This is a long-standing interest area of mine, and certainly I'm really grateful for the opportunity to look at the RVTS and understand the program. And I do understand it in so much more detail. It's not something that everyone understands well, but it's been a joy to start to understand this program better. One of the things, there were 5 evaluation questions, but one of the key things that was really intriguing was, well, why does the program work? For all the reasons in the literature and the evidence and what we know about the complexities of rural and remote medicine and working in AMSs, why? Why are they getting great satisfaction? Why are they getting great fellowship rates? And why are people staying in the same practice, not just the same community, in the same practice, despite the challenging working conditions and the complexity of being a doctor in those settings? So this was a key driver for the evaluation, and it's the substance of what I'm going to talk about now. But if people want to hear more about the wider evaluation, I'm more than happy to talk with you about that at another time if you contact me. So drawing on 27 interviews and discussions from an expert reference group as well as a stakeholder advisory group of experts in this area, we had to think about this question from the perspective of context. So what we wanted to understand and what we're trying to talk about here was we had to think about the registrars. They're in an environment where there's less resources, they're really busy with work and they don't have a lot of access to peers for professional networking. It's difficult to access training, but they do have past skills, as Pat mentioned, many coming to work in that community with pre-existing experience. But the sort of complexity of working in the community is there with a complex caseload. And in rural medicine, there's always the threat of making mistakes. It's just impossible to know everything. So that there's a feeling of being quite exposed when you think about the registrar's context, but also they can feel socially and culturally isolated. That's both for Australian medical graduates. You know, every time you move or live in a different community, it's completely different culture, completely different social dynamics, as well as for international medical graduates who, of course, have other barriers and need to go through that process of cultural integration and social integration. Then there's the context of place, and these locations have, as we've talked about, extreme workforce shortages. In fact, some of the worst workforce shortages we've seen in some time, especially post-COVID. There's limited time for learning, and there's an absolute necessity to deliver services. But the other side of it is that in that place, there's often limited referral options, limited local staff. You have to know what you can do and work at the maximum scope. And equally, the potential for fragile relationships. And of course, the registrar has a family. And so the family and the children and what their context is also a factor. So why is the RVTS getting good results? When we looked at the benchmarks for those things, it would point to worse. You should get worse results. So what we looked at then is Pat's described is the model, and we broke it down into, okay, the component parts of the model, which is another context to think about. The RVTS could be depicted by, and this is where we can learn about it in terms of supervision and support for any poorly resourced environments, is they use a non-hierarchical supervision model, which it's really about supervisors in the second box who know and acknowledge the background of the registrars. Often they had been through the program, they understood the community, they were able to offer calm advice, and they were familiar to the registrars. They stayed with the registrar throughout the journey as an independent supervisor, generally employed in another practice. And so they were a safe source of a safe contact point. The third box there is supervisors, and the model in general was really about proactive management. So layered real-time backup support at any point through no wrong door approach. So it wasn't just a remote supervisor, but it was program staff and other staff that Pat's mentioned who could each buffer and layer the approach. The teaching was explicit, regular and scalable, very tailored to the local need because everyone's skills and background was very different. And on top of that, the registrar and supervisor were able to access a community of practice that was once again non-hierarchical, about co-learning, respecting each other as equals and understanding that no one knows everything in the space of rural medicine. And finally, the program could be seen to be really on about recognising and including family and understanding the social connection and the meetings between registrars who work in similar contexts who may not otherwise know about each other. So using a realist evaluation approach, those three contexts were put together to explain why the registrars on the RVTS were getting good results and feeling professionally and non-professionally supported despite the challenges that I've talked about. And the model was 3 C's and 2 B's. So firstly, they felt comfortable. They could reach out and not be judged. People understood what it was like in the community when they called, when they picked up the phone. So it was psychologically safe to reach out for more help. They felt confident that at any time they could find help, they could learn more, the resources could be scaled up relative to need, and that they were never on their own, despite the challenge of trying to do the best they could as a registrar. And in terms of competence, that was so layered to cover all bases, including an explicit teaching program, but building competence for the specific setting, including communication skills, cultural training, understanding the Australian healthcare system, and right through to the procedural skills of rural general practice, rural and remote practice. Then the 2 B's were belonging. People for the first time sometimes felt seen as an individual and valued for what they did. They felt part of a special community of practice, and they found for the first time other doctors like them, and these rich relationships developed. And that comes to the final point, bonding, where people, when they did meet face-to-face in the workshops, made incredibly good friendships, both between registrars, but also between registrars and families. And there's a real sense of connection and family that continued to be there once people went back to their communities, and those relationships could continue online. And this all landed on the piece at the bottom, which was people felt a sense of professional status as a registrar, but a doctor in Australia with an emerging identity within a community of practice, valuing and respecting services in this setting. And that goes for thinking through then training in other resource poor environments. If the context is ringing a bell with a few people, then there's potential that this type of framework could be used to sort of think about not just training people through a remote supervision model, but thinking through the other things that need to be triggered for the proper, fulsome, holistic support that is required.
Thanks, Belinda. I think that was a lovely summary. I have some questions, but I think hopefully they might be refined and possibly even answered to a degree with these couple of case studies. But I might ask Sarah to present briefly one case. Thanks, Sarah.
Thank you. So think of a small town in New South Wales, population of 885. It's called a triple M5, which is the modified Monash scale. So pretty small country town, got quite a big drive to get there. Before 2020, there was no regular GP, a succession of a locum or no locum. In 2020, it all changed. There were 2 RVTS registrars. They shared a 1-in-2 on call for the hospital. It was a small multi-purpose service. So it had an emergency, acute beds, and long stay patients, so nursing home style. 2 registrars work 5 days a week in an increasingly busy general practice. Registrar 1 graduated in 2009 from overseas, had 10 years of hospital experience. 8 of those were overseas and 2 in Australia. In between 2020 and 23, the registrar completed all the training and assessment requirements for the RAC GP to obtain the fellowship, and is also a dual pathway ACRM registrar who completed an AST in a special skills in the tertiary hospital related to the town. So I was the RVTS supervisor providing remote supervision, which was 1 hour a week for 6 months, and then 1 hour a week a fortnight. And after that year, it became 1 hour a month. There's additional supervision required, and there was a period of time where we did access that, and it was, really helpful to support exam preparation, and particularly through some of the COVID time when registrars there were isolated, providing quite exceptional services to quite a large area with the COVID services and the collection centre. If I were on leave, there would be a relief supervisor. Yeah, how did we do this? We did it by phone or text or email, Zoom. Occasionally it was in person. We would meet. Actually, to be honest, it was really lovely because we bumped into each other before our VTS term had actually started. We had complete chance in Manly in one of the rural doctors' conferences, and I just recognized the name tag. So that was a really special bond that started beforehand. I've had a number of RVTS registrars over the years, the more recent years, but I don't want to sound too old. But gosh, the most amazing thing is the friendships that you create. I mean, I was a registrar myself, and I had a number of supervisors, and I'd like to think that they were friends, but the depth that the collegiality and the relationship that you have as a remote supervisor, for some reason, in every registrar I've had has been exceptionally special. And I think by case study, Registrar 1 has popped her head up. So,
Hi, Sarah. Hello, everyone.
So Salma is my case study 1 registrar. And I have to say, RVTS registrars are exceptional. They're really lovely to work with, really enthusiastic, very kind to one another, and support each other very well. And I think I would say the same with the supervisors. I feel across Australia, I have such lovely friendships with registrars and supervisors that you wouldn't possibly have if you weren't working in the remote supervision.
Yeah, totally
So I
indebted
might
to
just ask you while you're there, we've heard some of those key ingredients that Belinda's spoken to from the program, but as a recipient, what was it for you that allowed you to not only stay where you were in that environment, but thrive in that environment? What was the sort of special sauce, the secret recipe?
Yeah, the key word or the USP for RVTS, I think, is support, support, and support. And what Pat just covered prior to this, I would vouch for that 200%. We were supported from day one. We had the support at collegial level with our colleagues, from registrars, from supervisors, the MEs, and the constant webinars and education, and the constant encouragement that we got. I think the fact that they realized how rural and remote and isolated we were, and they kept that in mind while supporting us through this journey of the registrars while we continue to serve these communities. And as Sarah might cover, that these locations are difficult to manage and handle, but with supervisor support like Sarah's and with education support, webinars, we got through. We also got support through workshops, face-to-face workshops. COVID bummed it in the middle. We had a bit of online workshops and things, but still it was enough to help us gain skills and use them in our rural and remote locations. And yes, I would vouch for that. It's given me success. I've so far come through trying to complete my second fellowship, but with their assistance, I have completed the first fellowship. So I would say 200% everything that they have said, we have received that support in our communities.
Well, a big congratulations to you. I'm sure you've served your community very well.
Something that's really lovely as a supervisor is you really have to look at every registrar as a unique registrar. They're not one fit, they're not all the same as individuals with their family in their workplace. And as a supervisor, that's a really lovely challenge to try and work out who your new registrar is and what it is that you feel they need. So you're walking a path with them, running ahead in a remote concept, trying to move rocks around and make a pathway for them while you come back and walk that path with them. It's a really exciting role to be in. So you're not in the same practice as them, but you really try to ascertain from a distance how that practice is working. So we do clinical teaching visits that are face-to-face in the practice, and that's sort of quite a very insightful way to meet the staff and the practice and see the registrar in their community.
Simon, I think Selma and Sarah's experience really illustrates how development of this strong bond between a remote supervisor and the registrar, but also the importance of peer support. Selma and her colleague, the other registrar in the practice, were really looked after their town right through the COVID pandemic. And they did that with the support of each other, as well as their colleagues in other communities as well. I think I'd have to say, Selma, you've thrived with those challenges and have grown incredibly and developed your knowledge and skills over that time. And of course, Selma will be one of our supervisors and probable medical educators in the future.
Oh, well, Selma, it's lovely to have you on and wonderful to hear that endorsement, and a big congratulations to you. So I think David's arrived.
Yes, Simon, thank you. So I'm based on Noosa in the Sunshine Coast in Queensland. My role with RVTS started maybe 6-7 years ago as a remediation medical educator. I then took over responsibility for the AMS registrars as their medical educator. And then the last year or so, I've been Deputy Director of Training. So I've kind of worked my way up. My previous experience, I've worked for about 14 years in an Aboriginal Medical Service in Far North Queensland. And I was fortunate enough to be a supervisor for many registrars in that role. So it's been really useful to carry that experience as a supervisor in that particular environment into my role as an ME. And some of my task as an ME is kind of, as a supervisor sometimes, is to kind of coach them through the challenges of being in the workplace. But that's worked well, which hopefully this case will demonstrate. So the registrar that we're talking about is an Australian trained doctor. So you're probably aware that's not our usual, but it's usual enough that it's not a strange thing. But, as we'll see, he also faced some challenges. It's not only about coming from another country. So he actually first enrolled in RVTS in 2015. He ended up withdrawing from training after 6 months. His first CTV provided these comments along with others. He was lonely, feeling unsupported, getting burnt out, which probably doesn't paint such a good picture of RVTS. I'm not sure he is suited to self-directed learning. In retrospect, it was more a reflection of where he was at in terms of his journey, and he did get a lot of support during that 6 months, but it just wasn't suited to him. I think he'd made a choice that perhaps he wasn't ready for. But fortunately, he was able to return to us 6 years later, having obviously 6 more years of experience. He did initially on his early CTV with his supervisor, which is something we try to encourage, an early visit with the supervisor as part of what Sarah was talking about. Getting to know the registrar in their particular environment is quite important. But he was looking rushed and harried, and certainly as a support team, we got that sense that he was quite an anxious character. So his RTC, he formed a very good relationship with his RTC, and she was quite insightful. She recognised that he was feeling out of his depth. He didn't have any doctors on location, which is also not uncommon in our registrars. They're sometimes working by themselves, which you can imagine is quite challenging for a doctor in training, and one of the kind of difficult circumstances that we have to come up with solutions for. He was offered additional supervisor time, as Sarah mentioned. That's an option for our registrars. If there's an identified need, we can provide extra time. I also offered to talk to him, but he was kind of so anxious and shy that he didn't want to kind of upset anybody. So he negotiated his way through with the RTC, but fortunately, because of the good relationship they had and her particular skill set, he was able to negotiate quite a challenging time for himself early in his training, which was a potential opportunity for him to leave training again. He was kind of always on the edge of leaving this registrar, but that improved in that situation. So a year into his training, his supervisor, obviously having had regular contact with him weekly for 6 months, 2 weekly for 6 months, had picked up on a building kind of dissatisfaction with the governance of the AMS and the communication within the practice. For those of you with experience with AMS, you'll realise this is not an uncommon situation, hard enough to deal with if you're an experienced GP in this setting. And a lot of AMS doctors end up leaving because of this very thing, even if they've been there 5, 10 years. This can be the thing that breaks the relationship. So he was going through that at the time. Certainly, he was considering leaving. It was very stressful for him. This was before his exams. He was reluctant to sit the exams because he was so nervous. But again, he had kind of multiple inputs. This time, he did accept more support from supervisor, ME, and again, the RTC. We were able to kind of improve his understanding of his environment and give him a slightly different way to approach it that he wasn't able to get from his local environment. Initially, because there was no other doctors on site. But then when other doctors did come on site, they kind of withdrew into their shell and weren't able to provide that kind of mentorship that he was hoping for. But through our kind of extended mentorship role, we're all able to kind of guide him through it. So that lasted again for another year. I think he passed a few of his exams, but then sort of the next year, further ongoing frustration with a major change to software. Doesn't sound like a huge thing, but again, for those of you with experience in the AMS, it can be a major destabilizing factor, and particularly because change is often not managed well in the environment. It's kind of a decision is made and then inflicted on everyone rather than a kind of a formal change management process, which is certainly his experience. So we were able to support him in this way. Again, thinking outside the box, we had a number of staff that were very familiar with this software, which isn't a usual software. It's not common, but we had people with experience who were able to talk to him one-on-one to give him a better perspective on perhaps how he might fit in with the software a bit better. We also identified that there was a few registrars going through similar situation, perhaps not to the same level as he was. So we were able to organise a drop-in webinar, just an off-the-cuff webinar, not part of the regular training program, where we had an experienced GP come in and give a really good session on how to personalise the software. There was probably less than 10 registrars attended, but it was certainly very well appreciated and lots of discussion and questions at the end of the webinar. And we recorded that, make it available for future cohorts. And we actually created a WhatsApp support group. It was found to be so useful to kind of have that discussion. It's found to be reduce their stress levels so much that the registrars were very keen to create this support group. It wasn't frequently used, but certainly, and this registrar was probably one of the most active users. Once he felt the support, improved his confidence, he actually became a leader in this area and was able to support other registrars to help come to terms with this software. And then I guess something I haven't mentioned there, one of the approaches that we were able to provide to him with my experience of having been so long in an AMS, I'd worked at the very first start of an AMS and we developed into a multi-million-dollar organisation. I had that sense of the whole kind of spectrum and I was able to give him kind of permission to stand up and be a leader, like as a GP, say, okay, look, I've got some skills here, how can I be part of this change rather than just being a victim to the change? And he really kind of took that on board and it gave him a lot of satisfaction and I think improved the conditions at his practice significantly. So he got his fellowship earlier this year. In his completion of training, feedback and throughout, he certainly spoke very highly of the RTC, the relationship with the RTC. He was contacting her quite frequently and a lot of the time I wasn't even aware of it. She was able to just keep his kind of feet to the ground and working hard. ME supervisor, and we also have a cultural mentor program for those that work in AMSs and remote areas with high Indigenous population. So that's one-on-one contact for a couple of years where they have a local cultural mentor to help them negotiate through challenging cultural situations. So he was also able to benefit from that. So that's the case.
Thanks, David. So yeah, obviously quite a different context and a different set of circumstances, but demonstrating the support.
Simon, I might just point out a couple of resources. People may or may not be aware of these remote supervision guidelines from both colleges, and they're excellent, I must say. They're both very well put together and quite recent. ACRM's had ability for remote supervision for quite a long time, but they've really improved on it and made some specific guidelines, as have the RACGP. There's a but that goes with this, though. This is about supporting doctors in remote environments. What we've learned is that it's more than just remote supervision. As we've heard from David and Sarah, the supervisor-registrar relationship is really important, but what's most important that we've discovered is the whole package, the comprehensive professional support package. And that means supporting a registrar's professional and non-professional needs and putting them in an environment where they feel, as Belinda has pointed out, the 3 C's and the 2 B's: comfort, confidence, competence, belonging and bonding. I'll just leave it at that. I can expand on that a little bit, but let's see if there's any comments or discussion. But that's probably the main takeaway point, that it's not just about remote supervision. The supervisor relationship is really important, but for people in these settings, poorly resourced environments, to thrive, they need that whole package. They need the case manager, the registrar training coordinator, the medical educator mentor, the peer support, the family support. They need the whole works. And particularly for IMGs, they need to be valued. They need to be told that they're not working in a job that no one else wants to do, that they're in a situation, they're providing a really important service to their community and to Australia, because so many international medical graduates are working in situations where Australians won't go, Australian trained doctors won't go. And so we constantly telling our doctors what an important job they're doing and how it's our job to keep them doing their important jobs, to keep them there doing their important roles. And I think that resonates so much, particularly with the IMGs, but also Australian graduates, that they feel that they're not in a dead-end position. They're doing an important job and they're highly valued. And they return the compliment, if you like, to us as a training provider with great loyalty. And I suppose it feeds into that sense of belonging and bonding. So there you are. I'm starting to get a bit warm and fuzzy now. I'll stop. It's probably time I stop talking.
This is Valentina, guys. I am a bit biased, like a lot of people from RVTS will all love this organization. I've been with RVTS since 2015. And from very first contact with admin staff, you get the feeling that you are supported. At first, my location, which I've tried to apply, wasn't appropriate. And then the next year, when I've made another contact, admin person, Deborah, knew me and she said, great to hear from you again. So you get that sense of real personal attention. You get sense of care from just very step into the program. I've been with RVTS in different roles. At first, went through the training as a registrar, did a year of RLO job. After completion fellowship, stayed on as a medical educator and a supervisor. And the reason we all staying on and we're all willing to put our efforts in, it's those 3 C's and 2 B's. You feel like it's your family now, you feel you're belonging. In fact, on the very first day of training, the first workshop, Pat actually makes a big effort to come to every new registrar, introduce himself, and actually knowing the person, where the person from, knowing their CV. It's amazing. I still can't believe your memory. And I guess we all want to return. We all want to be part of the family. And it's lovely to see our people on the list. And we've been just SMSing hello to each other. Like Sarah said, it's a lifelong family and friends.
Thanks, Valentina. That's a great endorsement.
I feel quite strongly that RVTS has probably had a very good footprint in retaining doctors in rural areas, not necessarily through the training program as registrars, but as supervisors. So certainly for me, I know I was working solo, remote, small town, similar to Boggabri, and Pat had asked me a couple of times to be a supervisor, and there was no way I could understand how I could fit that in. A bit like you, Simon. I felt 24/7 on call, often the only doctor in town, but I couldn't conceive how I could do it. But when I did, it actually suddenly everything became easier. So the overworked doctor, it's anyway, I think it's really helped retention for me. And I think that's a story that I've seen with many other supervisors.
Thanks, Sarah.
This is in regards to keep working in the rural area. I've been working almost in the same location, but within 10 Ks for about 12 years now. That's just going back to your numbers, Pat, of the retention of people in rural area.
When I look at those Cs and Bs, in a sense, they don't surprise me. They're the sorts of things we kind of know and you see written down, and I guess supervisors would aspire to being. But I'm curious to know how you achieve those things. Is there some magic in this? Is there something that you could suggest as a sort of almost a closing suggestion to the audience around how to achieve some of these really important principles that, make for such a supportive placement? And we're talking, really at the kind of the micro level. What can a supervisor do or a supervision team do to meet some of these?
Yeah, I mean, my thoughts on that, thank you for that question, is that this stuff should be really baked throughout the supervision competencies, the supervisor training. If we really want to drive place-based, person-centered models that recognize these challenging settings, and that how do we actually stimulate and trigger registrars to feel properly, fully supported for the full person they are in that context, then I believe these triggers really are sensible words for a holistic package, as Pat mentioned, of what we need to think about pushing for. So so thank you for raising that point. And I think that the fact that it's landed on 3 Cs and 2 Bs might help us to remember it, but we could perhaps in time it may be called something different as a framework of some sort. Thanks, Simon.
Well, I'll give you the last word, Pat, as the head of a long-lasting and an extremely successful organisation.
Yeah, look, thanks, Simon. And it still is a successful organisation, and we have had great success over the years, and it's really a thrill to reflect on what we've achieved in that time. But the main takeaway is about supporting registrars. And it's not just about the supervisor, it's about the full support package, making sure that the content delivery, the training is high quality, but it's contextually appropriate. And it meets not only the curriculum requirements for passing exams, but gives people the knowledge and skills to be able to work in their contexts. And then to be able to set up an environment where people can support each other is just so powerful and creates a virtuous cycle, because almost 30% of our supervisors are former registrars now. We've grown our own effectively, people that get it. They understand the model, they understand the context, they understand what the needs are, they understand what the challenges are. That's been instrumental in providing a bit of a snowball effect to lead into that belonging and bonding that we talk about.
Yeah, great summary. Congratulations to you all as a team. One maybe last comment I would add is I'm a great proponent of pulling back the curtain and not just doing things to or at the trainee, the learner, the registrar, but actually allowing them to see what we're doing. This is why I'm doing this teaching method. This is why I'm doing this type of assessment. And I think there's 5 headings, we can and should talk to our learners, our registrars about. I want you to feel comfortable. I want you to have a sense of confidence. I want you to feel like you belong here. These are things I'm aspiring to, but without kind of articulating that, maybe I won't meet it as well. So maybe those themes, those triggers are very much, they're conversation pieces as well. Can I thank what is a very big panel Pat and Belinda, of course, and Sarah and David for your cases, Valentina and Peter. Thanks for coming along. Thank you so much for inspiring us, because I think that's what it has been. And I must say, Salma, thank you for coming on. That was, for me, probably the best bit. Just a recipient of the program, achieved so much and endorsing it so strongly. So thank you.
Thanks for the opportunity, Simon. Thank you, everyone.
Thanks for watching. We'd love your feedback. Please comment or subscribe to our YouTube channel for updates on new videos. If you'd like to ask a question or suggest a topic, you can contact us via our website at gpsa.org.au. GP Supervision Australia is supported by funding from the Australian Government under the Australian General Practice Training Program.